let's learn about the effects of the lithium on the kidney. Lithium is one of the most effective mood stabilizers for the bipolar disorder. It has got narrow therapeutic index and it has well documented renal toxicity. Effects are typically divided into acute, that is functional and often reversible, and chronic, that is structural and often irreversible. So let's move on to the acute effects of the lithium on the kidney. Acute effect. So the most common acute renal effect occurring in up to the 20 to 40% of the patient is nephrogenic diabetes insipidus. It usually appears after a long-term therapy, and sometimes it occurs or appears early too. So what happens is the lithium enters the epithelial sodium channel, that is intact channels, and accumulates intracellularly. It inhibits glycogen synthase kinase 3 beta, this protein, which downregulates the aquaporin water channel expression and trafficking to the apical membrane. So it inhibits this protein, the ZSK3 beta protein, which ultimately downregulates the formation of aquaporin 2 channels, due to which it is not trafficked into the luminal side of the principal cells of the collecting duct, and ultimately the collecting duct becomes unresponsive. Even if the ADH attaches to the ADH receptors, it is not able to form the aquaporin 2 channels, due to which the water, which is normally reabsorbed through this aquaporin 2 channel, is not able to get reabsorbed. So water cannot be reabsorbed, so the water is lost in the form of urine. Ultimately, the clinical picture the patient presents with are the polyuria, polydipsia, dilate urine, that is low urine osmolality, despite the high serum osmolality. It's usually reversible if the lithium is stopped early, and can become partially irreversible with the chronic use. So its effect is on the collecting duct and principal cells, leading to something known as the nephrogenic diabetes insipidus. So the second effect the lithium can have is acute kidney injury. So because why this occurs is because of the toxicity of the lithium due to the overdose or dehydration or its interaction with other drugs like NSAIDs, ACE inhibitors, diuretics like the thiazide diuretics. So what happens is, because the lithium enters into the tubular cells and causes this toxicity, that is the damage, and also hemodynamic effect of the lithium is often compounded by the volume depletion, and which itself is worsened by the diabetes insipidus, and it can present with prerenal azotemia or the AKI. So it is also reversible with a lithium sedation, hydration, and sometimes the patient may need hemodialysis in case of severe toxicity. So let's move on to the third effect of the lithium, that is distal renal tubular acidosis or type 1 TA. So what happens is the lithium causes the tubular damage, that is the collecting duct tubular cells, and ultimately it impairs the hydrogen secretion into collect duct lumen, and due to this the hydrogen ion is not excreted from the body, leading to the acidosis. Acidosis also, in compensation of it, causes the hyperchloremic metabolic acidosis, and is less common than nephrogenic diabetes insipidus, but it is well described. So now let's move on to the chronic effect of the lithium on the kidney. So it develops with long-term use, typically about 10 to 15 years of use of lithium, and histologically we can find interstitial fibrosis, tubular atrophy, and distinctive, that is microcyst, that is the dilated distal tubules or the collecting duct, and this microcyst is considered the fairly characteristic of the lithium nephropathy. So it causes chronic tubular interstitial nephropathy. So what happens is lithium, when a patient uses for the long period of time, it enters into the intact channels and accumulates and the persistent accumulates in the principal cells for a very long period of time, and very little is reabsorbed through to the blood. And what it does after persistent sustained lithium exposures, it causes the tubular damage, ultimately leading to the apoptosis and the necrosis of the tubular epithelial cells. The oxidative damage can also lead to the increase in reactive oxygen species, contributing to the cellular injury. Also, the local inflammatory cells infiltration can occur, and there is activation of fibrogenic pathway, especially to the transformation growth factor beta signaling, and it promotes the fibroblast proliferation and collagen deposition, leading to the fibrosis of the tubular cells. And this produces the classic histopathology of chronic lithium nephropathy, that is tubular interstitial fibrosis, tubular atrophy, and the microcyst formation. Yeah, and relatively sparse glomerular involvement can also occur. So what happens is lithium mediated ZSK3 beta inhibition causes the beta catenin accumulation and leading to the double anti signaling pathway, and chronic double anti beta catenin activation leads to the tubular proliferation and the differentiation, leading to the microcyst formation. So this is the hallmark of a microcyst is the hallmark histopathologic findings in chronic lithium nephropathy, and this is the same pathway implicated in polycystic kidney disease, which explains the cyst phenotype. Now, what happens when you use the lithium for also the next effect of the lithium on the tubular cells is when you use for the longer period of time, it causes the tubular interstitial damage, and when it accumulates for the longer period of time, the functioning nephron is usually lost. The functioning nephron is usually lost, and over time it causes the hyperfiltration, compensatory hyperfiltration, and ultimately leading to something called secondary FSGS, which contributes to the proteinuria in some patients. The net effect is a slow dose and duration dependent decrease in GFR, which can progress to CKD stage 4 or 5. So why it becomes irreversible? Maybe that comes to your mind when it becomes the irreversible. It's because early on, aquaporin 2 channel, which we had discussed earlier, suppression and mild inflammation causes are reversible with lithium discontinuation. But once the structural damage, we can see the tubular interstitial damage and the form of the principal cell transdifferentiation, tubular atrophy, interstitial fibrosis, microcyst formation occurs. The anatomical substrate for concentrating ability infiltration is permanently lost. That's why the clinical observation that the nephrogenic diabetes insipidus and GFR often persist after stopping the lithium in patients with long standing exposure. So let's summarize what we have learned so far. The lithium enters the principal cells via inactive channel. It inhibits GSK3 beta protein. It thus causes downregulation of aquaporin 2 channels, causing impaired water reabsorption, leading to diabetes insipidus. And when you use lithium for the chronic period of time, it causes the chronic activation of double anti and beta catenin pathway. And when there is double anti beta catenin activation, it causes the cellular proliferation and ultimately leading to microcyst formation. And also, ultimately these all lead to the tubular injuries, oxidative stress, and transformation and growth factor beta driven fibrosis. And there is chronic tubular interstitial fibrosis and nephron loss, which ultimately leads to the compensatory hyperfiltration, leading to FSGS, and this leads to the progressive CKD and also irreversible nephrogenic diabetes insipidus. So I think you have learned something today. So that's it for today. If you have any confusion, you can comment in the box, and we'll meet again with the next video. Thank you for your attention. We'll meet again. Thank you.